Hello, everybody. It's a pity that I'm not there with you in Bahrain to meet you all in person, but at least we're living in difficult times, so at least we can meet virtually. And I will speak about the European Action Plan for Stroke. And these are my disclosures. So as you may know, this process of the European Action Plan started in 2006 with the Helsingborg Declaration on Stroke Management in Europe. And there was already the idea of making stroke structured. And the domain that were involved were the organization of stroke services, the management of acute stroke, prevention, rehabilitation after stroke, and evaluation of stroke outcome and quality assessment. And that's very important. The quality assessment is one of the most important part of our work, because we need to know how well or how bad we are working in order to improve our daily work. So we understood that there was a need for a new Helsingborg Declaration, because we needed to, in a way, to improve stroke services around Europe. And we understood that the resources that governments put forward for stroke did not match for the society, the impact and burden of the disease, because 1 of 4 will have a stroke. So we needed the NCD. We also wanted to include the NCD plan in order to reinvest for stroke. And finally, you know that stroke was always together with myocardial infarction, with all the heart diseases. But we really were able to split stroke from heart disease, to give stroke its own dignity. And it's so important for you to remember that the return of investment for stroke is excellent. How more you spend, more you get back. So we decided in 2016 to proceed and write the 3rd Helsingborg Declaration, because also of the fact that we realized that in Europe, and you think Europe is a rich continent, too many patients were not treated in stroke units and stroke centers. And more than 200,000 patients could have been treated by IVE, and more than 60,000 patients with endovascular treatment. So after mapping what was going on acute stroke treatment, we did a mapping about secondary prevention services after stroke in Europe. And again, this was done together with the patient organization, with SAFE. And we again did a survey in order to understand how was the access and the delivery of secondary stroke prevention. And you see, in a way, it was even worse to what we find in acute stroke treatment, because emergency treatment is much easier in a way to get, because this is something that is life-saving. And you see, there was a quite more difficult scenario for secondary prevention. And what we realized, that there was, again, an east-west gradient. There were not the same lifestyle management programs in Europe. There was not the availability of fast-track transit ischemic clinics. So there was not, for example, not many hospitals have then follow-up of the patient, the access to AF monitoring. We know how important it is now. Not let's say the widespread use of let's say statins or other, like NOACs, and not let's say the correct way of the blood pressure treatment. So everything was in a way very well organized, let's say in France for TAA clinic, but in other countries you didn't find this well organized pathways for secondary prevention. So talking about our action plan, we can say that we started in 2018, and the first, and this was divided in 7 domains. And you can see what we did for the first time, for us stroke physicians, we included primary prevention. Part of the Helsingborg Declaration, such as organization of stroke services, management of acute stroke, secondary prevention, and organized follow-up rehabilitation and evaluation of outcome. You see that this was already present in the first edition, but we added also life after stroke, because we know that now strokes tend to be milder. Patients tend to live 20 to 30 years with stroke sequelae, and often they feel alone, they feel not follow up. So this is the part. This was especially written by patient organization. And then we had a separate group on prioritized research area for translational stroke research. So in every part of this document, there was the state of the art, the state of the current services, research and development priorities and target for 2030. And this is the publication. I invite you to read it. But I will bring you through what I believe are the most important points. So we have these overarching targets to reduce the absolute number of stroke in Europe by 10%. And it's doable because we have to work much better on obesity control, this is still, and you saw this probably in the recent global burden disease report by Valeria. Obesity is one of the, let's say, most important risk factor in increasing stroke risk. Lifestyle, we have to also clearly, this was written before COVID, and COVID will clearly worsen the prognosis of our patient, because we will have a poorer population, more social isolation. So it will be even a harder task than we thought it in 2018. Second point, to treat 90% or more of all patients with stroke in Europe in a dedicated stroke unit as a first level of care. Currently, when I start to look at my data in my hospital, I realized that only 50% of all stroke patients came to our stroke unit. So we said, okay, this is something that we need to change. We need to have national plans, and here we need politicians to be part of our plan by encompassing the entire chain of care in primary prevention to life after stroke. Very important. 80% of our stroke can be prevented, so we can do a lot. We are not doing the best, but even if in the case that we have a stroke, we have to, it's easy to have fancy, wonderful acute stroke units that we all have, but it's so difficult to support patients after or with sequelae of stroke, because these are not patients who are grateful. They always think about what they lost and not what they have. So it's a long psychological, let's say, burden for this patient. And we have to tell them, you are a success story, in order to feel that they are still, and you know they are often young patients, that they still have the full presence and full dignity in their normal life. And we need to fully implement national strategies for multi-sector public health intervention to promote, as I said, and facilitate healthy lifestyle, reduce environmental, including air pollution, socioeconomic and educational factors that increase the risk of stroke. I think pollution is now, everybody is talking about pollution after Greta, but still I believe it's important, because we know again from Valeria that pollution is one of the most important risk factor for stroke. So again, primary prevention targets. We need to have an universal access to primary preventive treatment. And you know, it's very important to say that we are not longer only working on high-risk population. We also need to work on low-risk and moderate-risk population, because it's we tend to forget this moderate-risk patients. And this clearly led to an unsuccess of many of this primary prevention campaign. And we need evidence-based screening on treatment programs for stroke risk factors in European countries. And I will never be tired enough to say again, control blood pressure. We know that 80% of our patients have high blood pressure when they have a stroke. So it's so important, and many of our patients are not on target when they come to our stroke units. Organization of stroke services. I believe that you have a wonderful stroke society, and I know that you are doing a wonderful job with your medical society and stroke support organization. Very important, because when you have a medical society with scientists working together with a stroke support organization, and you have the possibility also to speak with your health minister. You have the population involved, so it's much more easy to control the whole pathway. And for this, you need the pathway. You need to have the competent personnel. You know, for example, in Europe, what we are now fighting for is that we do not lose all what we created in the last 20 years, because now our well-trained nurses, they ask them, for example, my wonderful well-trained nurses were then, because they were very strictly formed, very good, they were then put in the COVID unit, because we are risking to lose the best our best personnel due to other competing diseases, and to have always certification and audited processes. As I said, what's about the management of acute stroke targets? To have more than 90% of all patients treated in a stroke unit, to have recanalization therapy, 94% of all the eligible patients across Europe, to decrease the door-to-needle time to less than 120 minutes from onset, not from door, and from onset to reperfusion, less than 200 minutes. And to have an IVT rate of above 50%, EVT rate about 5% in all European countries. And finally, as I said always, we didn't forget ICH and SIH, because we need to have a better case fatality rate, less than 25%, and a good clinical outcome, more than 50%. Secondary prevention, very important that 90% of stroke population should be seen by a stroke specialist. Very important. They have all the key investigational modalities, CT, 24 Holter ECG, echocardiography, transesophageal echocardiography, control for diabetes, to also that they get all the preventive strategies like lifestyle advice, hypertensive, lipid lowering agent, antiplatelets, PFO closure when needed. So very important, best treatment for our patient, because you can, one stroke can be solved when you have in a patient, you know, like cancer patient, when you could talk about recurrence, it's a devastating event, especially if we know that more strokes increase the risk of dementia. So it's very important that after the first stroke, we do our best not to have any kind of recurrences. Rehabilitation, early, you know, now we have the risk of patient being in hospital, that the risk to have more infections. And we try to discharge as soon as possible our patients from the stroke units, and to have an early support discharge, that patient can stay home, continue with physiotherapy, live fitness programs, and that all patients have a review of the rehabilitation or other needs at 3 to 6 months after stroke, and annually thereafter. Very important that we, you know, acute stroke, secondary prevention is now a science. We need to have the same scientific network also for rehabilitation. The evaluation for outcome and stroke quality, very important that we need to have the patient, that all physicians follow European guidelines. We have a common data set. It's in order to, in a way, to understand where could be the gap. if I see that in Italy there are worse outcome than in Germany, then I can try to understand why. What are the gaps in order not to have such good outcome if I use the same therapy? Where are my pitfalls? To have a national and regional level system to accessing, accrediting stroke clinical services, and to collect all patients' reported outcome and long-term outcome at 6 months, 1 year, covering both hospital and community care. Last target, life after stroke. It's so important that there should be teams responsible for championing life after stroke, to understand which are the minimum standards set for every stroke survivor, regardless wherever they live. To involvement of stroke survivors and carriers and their association, identifying issues and solutions that enable the development of the best patient and support practices, to have national stroke care plans, to support also self-management. And you know, now in COVID, we realized how important it is to have the implementation of digitally based stroke self-help information and assistance system. So we need, in a way, that these patients don't feel forgotten by us. So when they leave this moment of high technological stroke unit stroke centers, then already they come to rehabilitation. You see, it's already a downgrade if you're not lucky to have wonderful rehabilitation clinics, and then you can come back home with your deficit. So you need to coach them in order to say, okay, I'm able now. I had 1,000, 2,000 abilities. Now I lost one of them, but I still have enough to be independent. So these are the proposed timeline. You see, we have review targets in 2021. So it will be a little bit delayed after due to the fact that we had COVID. The midterm, we have a midterm review in 2024. Review of targets in 27, and the final year in 2030. So what are the things to do? We need, as I said, an epidemiological surveillance. We need to collect the data of all the national and regional stroke quality registries, estimate also what are the cost effectiveness, and we need capacity building, including education, certification. And you see, we are very lucky that we have all our countries in Europe on board. So some of them already we did, for example, there was an intention of work which was already signed by many of the health ministers in Europe. This was signed by the Bulgarian health minister, by the Ukraine health minister. So a lot of things are going on in order to be successful. And we need also to identify the champions. Why to identify the champions? In order to use the best models to get the best results. And you see, for me, one of the champions are the Austrian Stroke Network, because they already calculated how many stroke centers they need, how many stroke units they need, and they closed and they opened where a stroke unit were needed. And currently they have the 15% of thrombolysis rate with a 5% of thrombectomy rate. So they already reached this level. Same for the Catalonia model. They reach 15% of thrombolysis and 5% of thrombectomy. We need to measure, so we have now the rescue registry, where we measure the quality performance of our members, and they can see how they performed stroke unit care, for example, in 2020 compared to 2022, or in the month of March of 16, again in May 18. And this all this together was part of the quality improvement program for ESO. And all this quality improvement project is part in order to implement the European Action Plan in Europe. So I hope that I gave you an overview what we are doing. And I don't say that you should use but take from our European Stroke Action Plan what you think can be adapted to your region in order to improve stroke unit care or stroke center care in your country. Thank you very much for your attention.